So in the first part of this conversation, we described various descriptive studies. I'd like to welcome you back now to the second part where we will focus more on analytic or analytical studies in clinical epidemiology. So here's that figure we saw earlier, and we're going to be focusing on analytical studies, that is, those who are here in this box. And this may look a little bit confusing, but I urge you to think primarily about those three on the bottom left, that is cross-sectional, cohort, and case control. Those are the main three study designs that we deal with. Now, off to the right of cohort, we see an experimental study, and we will talk about that, but in truth, that is kind of a cousin of the cohort study. So when I think about study design, I think primarily of those, especially analytic study designs, I think primarily of those three, that is case control, cross-sectional, cohort, and experimental. And in MECOR and operations research, we tend to focus mostly on cross-sectional and cohort, but we will address the others through this conversation. Okay. So with analytic or analytical studies, the goal is to do more than simply describe what we see in front of us. It's also to characterize an association between two health factors, and ideally those should be considered or named before the study starts. So in particular, we're looking to see if a given exposure, sometimes called a predictor, may consider it as a risk factor. We're looking to see if a given exposure or risk factor is associated with a given outcome or disease condition more than we might expect by chance alone. Okay? So we're looking to see if there's a significant association there. And we do this typically by testing a pre-specified hypothesis. That is, we start out with a hypothesis, for example, that smoking causes lung cancer. So we can then design a study. We can choose a study design and a tool to address that hypothesis, to examine it, to see if it rings true. The measure of association then between that exposure and the outcome, it quantifies the results. And typically it is given as a number as a relative risk or also as an odds ratio. And I invite you to think of those two as simply being different measuring sticks, as it were. So we get different units, so to speak. It's really very similar to looking at temperature as either being given in Fahrenheit or centigrade. The temperature stays the same, but depending on which thermometer or measuring stick you use, in this case relative risk versus odds ratio, the actual number may differ, but they both show the same thing, which is that association between our exposure and our outcome. People also think of, we in clinical epidemiology think of analytical studies in terms of observational versus experimental. Now, for observational studies, the meaning of it is right there in its name. The investigator is simply observing a natural course of events and recording them. A classic example would be smoking and lung cancer. Some people choose on their own accord to begin smoking in their lives, and we as the investigators would follow those smokers through and compare them to a group who chose not to smoke, and we would find, amazingly, that those who chose to smoke would have an increased risk of or incidence of lung cancer through the years going forward. Experimental studies are similar with one important difference, and that is the investigator controls the exposure and then measures the effect on outcome. Now, the reason we do this is that it allows us to decide on a random basis who will be exposed and who will not be. And if the exposure, for example, is to a given medication, medication A versus medication B, we will then, through this randomized assignment of med A versus medication B, will be able to have some confidence that the two groups are comparable with other factors that might affect our outcome. So again, the experimental study is a true experiment. We decide whether a given individual gets exposure A or exposure B, and then we follow them through. Now, this isn't possible for many study questions. For example, with smoking and lung cancer, it would not be ethical to assign some people to smoke through their lives and to prevent others from smoking through their lives. So that type of a study, always has to be observational. But if we're looking to see if medication A is better than medication B, then it's very helpful for us to be allowed to randomly assign who gets exposure to medicine A versus medicine B, and then we can follow them through, usually to a good outcome, not lung cancer in this case, but usually to an improved health outcome, ideally a cure. So the design for these observational studies, there are three main studies, and I referred to these earlier in our conversation. The first of these is the cross-sectional study, which examines exposures and outcomes at a given point in time. So at one point in time, we have a contact with a participant, and we can ask them about both their exposure and their outcome. So, for example, we know that exposure to asbestos causes a malignancy called malignant mesothelioma. So we would be able to ask an individual, have you had exposure to asbestos, and do you have malignant mesothelioma? And we would go through a series of people until we had a large enough study in order to look at the association between asbestos and malignant mesothelioma. So that's a cross-sectional study. It's a cross-section. It's one point in time. Again, it's like a snapshot. The second major study design here is the cohort studies. And cohort comes from a Latin term that refers to a group of Roman soldiers in the Roman army who march together. And so a cohort is basically a group of people with similar characteristics walking together through time, marching together through time. And what the fundamental aspect of a cohort study is that at the very beginning of the study, nobody has the disease of interest. So with smoking and lung cancer, you're starting out, for example, with young people, let's say age 18, and none of them have lung cancer. Some of them, however, have decided on their own to smoke, and we will then follow them and the group of non-smokers forward through time, through the decades. And of course, we will observe that those persons who chose to take up smoking had a much higher rate or incidence of lung cancer through the years. So that's a cohort study. People are marching through time. That's a critical aspect of it, this passage of time. A case control study is, in a sense, the other side of the coin from a cohort study. Whereas in the cohort study, we started with a group of people without any disease and separated them or followed them according to whether or not they were exposed, such as smokers or non-smokers. Well, in case control studies, it's the other way around. What we do is we start out with a group of people with the disease, and we could call that a case series, and then we compare them to a group of people without the disease, and we might call that a control series. So we compare their profiles to look for associations. So a classic example, again, with smoking and lung cancer would be we would take 100 people with lung cancer and ask them what their smoking history is, and we would expect it to be high. And then we would compare that with the control series of 100 people without lung cancer, and we would expect their level of smoking to be low. And indeed, that's what we see. So for a cross-sectional study, here's an example. Basically, an entire population is sampled, and subjects are queried or surveyed to measure the prevalence of exposure and outcome at that one point in time. So you can see from this study there are 4 empty boxes, so we generally call this a 2-by-2 table, and each individual who comes into our study, we determine at that one point of contact with them, are they exposed, yes or no, and do they have the outcome or disease of interest, yes or no. And based on their answers to those questions, we put them in one of those 4 boxes. So someone, for example, who is exposed and has the outcome would be in that top left box. Someone with no exposure and no outcome would be in the top bottom box. So Basically, it involves filling in the boxes in that 2x2 table. And that 2x2 table then allows us to assess whether or not there's an association. That is, are those with the exposure more likely to have the outcome than persons without the exposure? So here's an example of a cross-sectional study, excuse me, that looked at sex disparities in the treatment of persons with suspected tuberculosis in rural Uganda. And at the very bottom there in bold, we can see an assessment of whether or not persons who had suspected TB received high-quality care. And that care is indicated in the lines above it. That is, was an AFB ordered? Was it completed? Were they referred for treatment? So they came up with a sort of a composite outcome, which is, did they receive high-quality care? And you can see that overall, in that first column, or leftmost column there, about a little more than a third, 38.5%, got good care. But it was not the same in men and women. For men, 45.6% of them got good care, and for women, it was only 33%. So this difference of 45.6% versus 33%, although it could have happened by chance alone, it would be very unlikely by chance alone. The likelihood of that kind of a difference occurring by chance alone is less than 0.001. That's what the p-value is. So in general, with this study, we would reject the notion that it's simply a chance finding. We would rather accept it as a significant finding that indeed men seem to have a greater likelihood of receiving high-quality care than women do. And this has obvious implications for program management. The advantages of cross-sectional study is that it's relatively quick and inexpensive, so it doesn't require a lot of resources. We can also, in our point of contact with each participant, we can ask them a lot of questions. So we can ask about various exposures and various outcomes. We don't have to stick with just one exposure and one outcome. If it is population-based, that is, if we are sampling our study sample comes from a population and reflects that population, we can estimate the burden of disease. So, for example, if we find in a cross-sectional survey drawn from a population that 20% of our sample is smokers, we can infer that probably for the larger population, it's also about 20% prevalence of current smoking. The disadvantages of this study are, first, that it measures only prevalence, what disease is present or prevalent at that moment. It doesn't measure the occurrence or the rate of occurrence of new cases. That is incidence. I think of incidence as a velocity of new case formation, or it's the rate that new cases occur through time. With a cross-sectional study, it's also difficult to use this as to prove a causal relationship. Frequently, we don't know which came first, the exposure or the outcome. And so what these studies show is association, but it doesn't necessarily prove that association is causal. And finally, it's inefficient for rare exposures or outcomes, because if only a very small number of your participants have the outcome or have the exposure, it's really difficult to get a precise notion of what the level of association is. A cohort study occurs again with a cohort, that is, people who are healthy with respect to the outcome of interest at the beginning, and we determine first what their exposure is, and then we follow them through time to look at the rate of new case development, in other words, the incidence through time. And at the beginning of the study, the predictor or exposure variables are measured, and then again, participants are followed through time to look at the level of outcomes that occurs in the exposed group versus the unexposed group. We could conceive of that graphically as shown here. So we've got a total population, and again, this is a population of people who do not have the disease of interest yet. Some of them are exposed, and some of them are non-exposed, and we query them to determine who is who. We then follow them through time, and as you see here, some of the exposed will develop an outcome and others won't. And the same is true for the non-exposed. Some of them will develop that outcome of interest and others won't. And this allows us to calculate the incidence, or the rate of new case formation. It's usually given as cases per person time, such as cases per 100,000 per year, as an example. So we look at the incidence in the exposed, and we compare it to that of incidence in the non-exposed. And we use it as a ratio, and it's called the relative risk. So, for example, if we see a relative risk of lung cancer for smokers of 10, what this means is that the incidence of lung cancer in smokers is 10 times what it is compared to the incidence in the non-exposed, non-smoking group. The advantages of this cohort design is that it's very efficient for rare exposures. It can measure incidence of the outcome. That is, we can know what the true risk is. That is, the likelihood of developing the disease through time. So that's incidence. We can also examine multiple outcomes. We don't have to look simply for successful treatment of tuberculosis, for example. We can also look at outcomes such as heart disease or ability to get back into the workforce or go back to school or what have you. We can also establish clear temporal relationship between the exposure and the outcome. Because of the way the study was designed, with a population of people who did not have the outcome of interest yet, but we were aware of their exposure, it's very clear that first came the exposure and then came the outcome of interest. With a cross-sectional and some other study designs, that's not always clear. Okay, so the temporal relationship is key. Disadvantages are that it can be inefficient for rare outcomes. So, for example, our earlier example of malignant mesothelioma as being caused by asbestos. Malignant mesothelioma is an extremely rare condition. It happens, a handful of times per million people per year. So I think you can appreciate the large size of the population or the sample you would have to follow through time before you got even one or a couple of cases. And unless you have sufficient cases, it's very difficult to do analysis. So the cohort study is, in a sense, the Achilles heel or a weakness or a disadvantage of cohort studies. Secondly, they can be very expensive and time-consuming as you're trying to keep track of all your participants and connect with them through time. And also the validity of the results can be seriously affected by losses to follow-up. If somebody starts the study but then leaves it, you don't know how well they did with their exposure, and that can be cause real problems in interpreting a result. Here's an example of of lung function and chronic obstructive pulmonary disease, COPD, in association with cooking fuels used in kitchens over a 9-year period. So this is a 9-year prospective cohort study. It's a cohort study because we started out with a group of people who did not have a COPD at the beginning, and some of them chose to accept an offer for using clean cooking fuels from that point forward in time, and others wanted to stick with their usual cooking fuel, which I believe and often was biomass, wood, and what have you, which, as we all know, puts out a lot of smoke and other pulmonary pathogens. And what they found here is that replacing biomass with biogas led to a reduced risk or incidence of COPD, and also a better maintenance of pulmonary function through time. We all know that pulmonary function through time tends to go downward, to decrease, but the rate of decrease in people who had the clean cooking fuel was less than we saw in the persons who were using biomass. So this, again, has obvious implications for public health. Okay. Now, experimental studies I think of as basically a cousin of the cohort study. They are clearly cohort studies in that we start with a group of people who do not yet have the outcome of interest, and that might be cure of a given disease, by the way, and we expose them usually to a series of medications. If it's only two, it will be Med A versus Med B, or various other treatments. And the treatment that the patient receives, that the participant receives, is generally based on a random assignment, so that our own clinical judgment doesn't interfere with things and make the groups non-comparable. The randomization is to help us achieve comparable groups. So the exposure then is controlled by the investigator, and subjects are followed to determine the outcome. So treatment, in the example here, we've got treatment group and the control group. It might be new medication A, where the control group is a standard medication and for a given disease. And what we're doing is following a group, all of whom have the disease, some of whom are being randomized to the new medication versus the old medication, and they're followed through to the outcome, which would be cure of that disease. And we would like to see if this new medication results in a higher level of cure than does the old medication. So experimental studies provide the highest level of evidence and support. They are, in a sense, the gold standard. Randomization is an essential component to this. And again, the reason we randomize is to make sure that the groups that we have are comparable, so that when we see a difference in outcome, it can only be due to the only difference that exists between the groups, which is the treatment. Because everything else, the age, the sex, all these characteristics that we know and some we don't even know, are on average equaled out between the two groups. So it allows us to say that the difference in outcome is due to the only difference that exists on average between the groups, and that only difference is the treatment. So we don't have to worry if there's something else in the background that caused our results. Ethical considerations are obviously critical here, and I earlier gave the example of it would be unethical to assign some people randomly to smoke cigarettes through their life and others not to smoke through their life. So we have to make sure that the treatments that we give to people, especially the controls, if it's a placebo, for example, that those have to be ethical. So if we want to give a placebo, for example, and there's already a standardized, recognized medication that's used for a given disease, that would be unethical because nobody is treated with placebo for this disease. There's already a standard. So our control group would have to be the patients receiving the standard, and the experimental group would be that with the group receiving the new medication. They tend to be expensive and time-consuming, but depending on the problem and the issue and so forth, they are usually worth the expense. Here's an example of a clinical trial which looked at a standard 6-month treatment for tuberculosis as the control group compared to a new 4-month regimen for TB with moxifloxacin. And again, this is in that New England Journal of Medicine, and what it showed was that the moxifloxacin regimen, the new regimen, was found not to be as good as the standard regimen. So that was obviously probably not the result that the experimenters or that the authors were hoping for, but it's important nevertheless, and it accordingly was published here in the New England Journal of Medicine.